Jean-Louis, thank you very much. Ladies and gentlemen, good morning. I didn't have any dreams last night, and I think I slept an awful lot better. So I suspect it was the quality of the wine rather than the quantity that the last two speakers were consuming. I've been asked to talk about how to guide therapy in the high-risk surgical patient, and as in my last couple of talks, it's been a privilege to follow a whole series of speakers, which has meant that an awful lot of the principles that I'm going to allude to have already been covered. So the principles of guiding therapy for acute heart failure, for low cardiac output, for hypotension, are effectively going to be the same principles that we're going to be talking about for the high-risk surgical patients. The difference here is that we actually do have some data to tell us what targets we can use and we can aim for. This is a big problem that I'm sure that we are all aware of and we'll see in our practice. There are a significant number of operations, major operations that are occurring in Europe every single year, and a lot of these patients develop significant complications and many of them die. I want to try and present some data to you that suggests that we can prevent some of these complications happening, and if we can prevent the complications happening by targeting our therapy appropriately, we can have a major impact for these patients. This is data published by Curie from the United States a few years ago, and I apologize that the graphs don't really come across nicely. I've tried everything to tartan them up, but I can't. Demonstrating the effect of a complication following either aortic aneurysm surgery or perhaps a low-risk procedure, laparoscopic cholecystectomy. Following the patients out for 5,000 days, so we're talking the best part of 15 years, and looking at the survival probability of these patients. If a patient develops a complication following surgery, there is a major impact not only on their short-term consequences in hospital, but their long-term likelihood of surviving. This is more data published in the New England Journal earlier on this year, again from the United States, looking at outcomes following surgery. This looked at a large number of hospitals in the States. This ranked these hospitals depending on their risk-adjusted mortality, demonstrating that the complications and the major complications are occurring reasonably consistently throughout these hospitals, but the mortality from these complications, if they're picked up, treated quickly and appropriately, has a major difference. So the message to me is that, of course, we want to prevent complications happening, but we also need to develop systems that identify the complications when they do occur and treat them appropriately. If we can do that, we can have major and significant beneficial effects for our patients. Now, what we're really talking in this session is the hemodynamic consequences, what we can do to guide our hemodynamics to try and prevent these patients developing complications. And I'm sure we've all seen excess fluid administration to our patients, and the one message I want to give to you is that goal-directed therapy is not about giving too much fluid. It's giving the right amount of fluid to the patients at the correct time. We can try and construct, this is a bit of a cartoon, but we can try and construct a survival plot depending on how much fluids the patients are giving. If we give too little fluids, if we've got too restrictive an approach, if we're not monitoring and rendering them hypovolemic, we have a whole series of complications. They're going to be dehydrated, hypoperfused, they're going to develop renal dysfunction, cardiac abnormalities, and anastomotic failure. So it's quite clear we don't want to leave them hypovolemic. But it's also quite clear that we can't just give them too much fluid. We can't guess and get it wrong, because if we're overzealous in our approach, we have all the consequences that I'm sure you're aware of. They're going to develop peripheral edema like the pictures I've just shown you, pulmonary edema, perhaps cardiac failure and other complications, anastomotic breakdown and so forth. What we want is to take this middle ground. We want to be in the zone in the middle, which is just right. Now, for low-risk patients, for many of the patients that you're going to see in a normal operating list that haven't got cardiovascular abnormalities, we've got quite a wide safety margin. We can do just about what we want and the patient's going to get through it. Our problem is when the patients develop cardiovascular or respiratory pathophysiology, the safety margin's narrowed. Our margin for error is that much smaller. We need to titrate our fluid challenges. We need to titrate our fluids and perhaps our inotropes very carefully. Otherwise, we run into problems. This is the group of patients that we need some form of sophisticated hemodynamic monitoring package. Now, if we look back in the literature, there are a number of variables that have been shown to be associated with complications and mortality. Now, this is data taken from Shoemaker 25 years ago. the relationship between oxygen delivery on the x-axis and mortality is quite stark, and it is quite striking. The lower the oxygen delivery, the lower the perfusion during surgery, the higher the mortality. Now, this has been shown by many others, and this is shown in our series. This is looking at all of our data and taking out a kind of multi-registic regression analysis. In our post-surgical patients, we found 3 variables that were associated with complications and subsequent mortality. That was the POSSUM score. For those of you who don't know what the POSSUM score is, it's a severity of illness scoring system that's kind of calibrated for surgical patients, but also the central venous oxygen saturation, the cardiac index, and the oxygen delivery. So it's quite clear, I think, that markers of oxygen flux, markers of oxygen delivery in the surgical patients are very important. Of course, we demonstrated this a couple of years ago, but Shoemaker had demonstrated 20 or 30 years beforehand. And this is where the supranormal goals and targets originated from back in the 1980s. We're all aware of this magic number of 600. I'm not sure it is a magic number, but the so-called magic number of 600, or perhaps a cardiac index of 4.5. That's where these studies originated from. They're targets that he identified as being associated with survival. There's a whole series of studies in the literature that have targeted or specified protocols to see if targeting these variables can make a difference. This is the protocol, we talked briefly about it a couple of days ago, that we did at St George's. Rupert Pearce was the first named author. This is post-surgical patients. The patients come back following theatre, they come to the intensive care. We institute monitoring. In this study, we use the LIGCO Plus system. We titrate our fluid challenges to achieve a maximal stroke volume. So we're giving 250 ml fluid challenges, looking to get onto the plateau part of the Starling curve. Once we've achieved the right volemic status, or what we perceive to be the right volemic status for these patients, we then try to increase the oxygen delivery. Now, all of the studies describe this as a magic target, this 600. I don't think it is a magic target. I think this is the upper level that we're trying to achieve, because a lot of the patients in our study never got to a target of 600, even with inotropes, because we're trying to individualize the therapy at the bedside to ensure we don't develop complications of tachycardia, myocardial ischemia. So we're saying that we're aiming for a ballpark figure. We're aiming for an oxygen delivery, perhaps between 500 or 600. We're taking the hypothesis that in most of these patients in the post-surgical setting, their delivery or their perfusion needs to be increased. We're doing it by volume therapy and a small amount of inotrope, but we're individualizing it so that we don't cause complications. If you look at what happened in the 6 to 8 hours following surgery, this is oxygen delivery against time in this study. The black bars is the control group. It's quite clear that we don't measure oxygen delivery and cardiac index. If we then don't target our therapy because we're not measuring it, we have no effect. The patients come back with an oxygen delivery of 500, and it remains at 500 for that 8-hour period. If you measure it and then you target it, we target it with fluids, don't forget, then we give a little bit of inotrope to some of the patients, perhaps a little bit of blood, but not very much at all. We can increase it. So we managed to successfully increase the delivery for the population as a whole to 600, but please remember that probably about a third of those patients never got anywhere near the 600, and they never would. It's not about a blind target to push your therapy against. It's about making a sensible decision. We're setting ballpark goals and targets that we're aiming for. Then when we're with the patients, we're individualizing the therapies appropriately. So by increasing the oxygen delivery in this post-operative period, we were able in this study to have a significant reduction in the number of complications and the patients developing complications. And this translated through to quite a significant impact in terms of the length of stay and the resource use and the time the patients spent with us in hospital. There was a 2 to 3 day median reduction of stay. If you look on economic terms, there was a 12 to 13 day reduction in the mean length of stay, because we were preventing some of the complications that caused the patients to stay into hospital maybe 80 or 100 days after surgery. Now, there's a whole series of studies in the literature that have taken different approaches and different strategies to this, but I think the principles behind the guidance of therapy are very similar. This is a study by Steve Noblert and our Horgan's group from the north of England looking at colorectal surgery. We're now targeting our therapy in the intraoperative stage rather than the post-operative setting. In this study, they've used an esophageal Doppler monitor. The first step is to titrate fluid challenges against flow time, as Professor Singh has talked to, but also to achieving a maximal stroke volume. This has been backed up, this has been followed and copied by many others. Howard Wakeling presented his data, which is a very similar protocol in a similar subgroup of patients. Number of messages I'd take from it. Again, this is plotting cardiac index rather than oxygen delivery in this graph against time in the intraoperative setting. The blue is the controls. If we don't measure cardiac index, if we don't target our therapy to a variable, we have no effect. The cardiac index remains about 3 and stays about 3 throughout the time. If we measure and target our therapy, we can increase it. In their study, by increasing it, the patients were discharged from hospital earlier, had a return to fitness sooner, and a reduction in complications. So I think there are a number of strategies we've got. There's a number of principles we can adhere to. And a lot of these have been spoken by the previous authors, previous speakers, but they're very simple. We want to correct volemia. If we're going to correct volemia in this setting, I think we should be targeting our fluid challenges to stroke volume. We can measure that or monitor that with a number of different technologies. I'm not going to stand on here and push one against the other. But I think it's important that we use the flow parameters to improve the outcomes of our patients. Now, this is a meta-analysis of some of these studies. There are now 20 or 30 studies in the literature which looked at some of these approaches. You can see here this is presenting a meta-analysis of these studies to see the effect on complications following surgery. There's a highly significant effect in all of these studies when summated that reduces the incidence of post-operative complications, and we've already alluded to the fact that that can have significant and dramatic effects to these patients. Perhaps we don't want to focus just on complications, so this is a meta-analysis plot. Now there's slightly more studies because more of the studies in the early days were reporting mortality rather than specific complications. But look at this highly significant effect, reducing mortality using a goal-directed approach in the peri or post-operative setting. Now, some early data that we've got, we're not 100% sure what this means, is from the first optimization study that was performed at St George's by Owen Boyd about 15, 16 years ago now. Last year we decided to try and follow up what had happened to these patients. I rather thought that 15 years after major surgery most of the patients would be dead, and perhaps that's right. But what we've got is a follow-up study now, 15 years after the first goal-directed study that Professor David Bennett sat at the back in this room today and Owen Bennett performed. You can see that the protocol group had a major survival improvement following the goal-directed therapy approach. The median survival of the protocol group was 1,780 days as opposed to 670 days in the control group. That's an increase of about 3 years. That's a significant increased survival. Now, I don't fully understand why a short goal-directed therapy approach can have an impact on long-term survival. It's quite clear that it's reducing complications, and by logistic regression we can see that the 3 predictors of improving or increased longevity are age, the development of a complication, or the study arm that they were randomized to. Now, I can't quite get my head around the physiology of what's actually happening with this, but it's interesting data, and it is very similar to the data that Curie presented, and I presented at the beginning of this talk. If we can prevent a complication in the intra or post-operative setting, it's not just a short-term effect, it's having an impact on the longer term, and it's worth doing. I don't know fully why or what's happening, and perhaps that's going to come out in a bit of debate. Maybe someone will come up with the answer in a few minutes, but I think it's something we need to look at. Some of the outcome measures we're looking at in intensive care are perhaps too short, and we can extend them out and look what's happening to longer-term survival. So how can therapies be guided in this patient group? I think what we're really talking about is setting some ballpark figures, some targets, some guides to help us to guide our therapy. We focus or tend to focus on oxygen delivery and cardiac index, but I would advise you not to forget mean arterial pressure. So to me it's essential to have an adequate mean arterial pressure and an adequate perfusion. If we look at the POISE study from earlier this year, when they gave inappropriate beta blockade to intraoperative patients, they dropped the blood pressure too early and had an increase in stroke and mortality. So we don't want to just focus on cardiac index and oxygen delivery. Please don't forget an adequate mean arterial pressure as well. I think titrating therapy to perfusion implies that we have to measure flow. We have to measure stroke volume or cardiac index, or perhaps construct oxygen delivery in this patient group. Our first step, like all of the previous authors, is to optimize the volemic status. I think in this setting that means targeting our volume challenges against a maximal stroke volume. We can integrate perhaps some of the functional hemodynamic parameters, but they haven't come through in the outcome studies properly in well-performed studies that I'm aware of as yet. In the post-operative setting, I think there is some evidence to suggest that oxygen delivery as a target is useful and can improve the outcome for the patients. So what we're talking about is setting kind of guides or ranges for titrating our therapy. We're saying in the post-operative or intraoperative setting, we want a mean arterial pressure, I've put in this graph, somewhere between 60 and 100. And we want an oxygen delivery, I've put an upper range of 600, but actually what we're really talking about is increasing it in the post-operative setting. If it's 300, maybe going to 350 is beneficial, but we've got an upper limit where we wouldn't push it any higher. And then during that intra and post-operative setting, we're trying to move the patients into these kind of ballpark figures. Now we can move the mean arterial pressure up, we can move it down a little bit depending on the patient's setting. But what we're trying to do is to titrate our therapy to individualize it at the bedside or in the anesthetic setting to make sure our patients have appropriate targets and endpoints. So, John Louis, summary slide. These patients do have a significant morbidity and mortality. I think there is some evidence in this patient group that guiding therapy can prevent these complications occurring, and that may have a longer-term impact on these patients' survival. I think if we're going to guide therapy, we need to monitor it. That means that we need to take these devices, and I'm not going to stand on the podium and say this device over that device. I think that's for you to make the decision or the rest of the panel to tell us. But if we do guide therapy appropriately, it can have a significant impact on their outcome. Thank you very much.